Good afternoon. Thank you for joining us. This is Public Health and Minority Health Disparities Subcommittee. It is Thursday. It is not April 1st. It is Thursday, April 3rd. And we are going to jump into this agenda. We are going to hold Senate Bill 447. This is the bill that we discussed before, which is the emergency pregnancy-related medical conditions. We're still working through some outstanding questions with the Attorney General, so we are going to hold that bill. But I did not want to postpone our briefing because we've had to postpone twice. So we are going to hold our briefing today. As this subcommittee knows, we had a bill previously on xylazine and medetomidine, and so we did ask the department to talk to us about what they're seeing, what they're doing, and the trends, so that we can better understand where we are and where we go from here. And we did invite Delegate Pippi, who had a bill on this issue, to join us today for our briefing. And so with that, I am going to go ahead and turn this meeting over to the department. And thank you again for convening with us and talking us through this issue, because
So
we
this has been an operation.
Once again, for our members who are just arriving, we are holding Senate Bill 447 for today. We are just holding the briefing because we are still working through some outstanding questions. So we will not be voting on Senate Bill 447 today, pending some additional information, but we did want to move forward with our briefing because we've had to postpone twice. So thank you very much, and I will now turn it over to the department.
Good afternoon, and thank you, Delegate Bagnall. And it is nice to see all of you on this Thursday afternoon. We would like to extend our sincere thanks for the ongoing partnership and collaboration that we receive from the House as we look to address what is happening for Marylanders in relation to xylazine and medetomidine. So as you will see during the presentation, significant resources are required for the Department of Health to build and maintain an infrastructure and capacity to monitor and respond to volatile and dynamic drug market, drug use, and substance use disorder. And the department's focus remains there instead on supply reduction. I will offer, if I may, a bit of a mea culpa regarding the letter of opposition and give some context for that if it wasn't clear in our letter. Is that, the department historically in our role does not regulate these entities, but we are happy to be here today to share information on the work group and current efforts since. And we are always happy to work with our legislative partners to make sure that we are securing adequate funding, support, and technical assistance for best practices for addressing illicitly manufactured fentanyl with xylazine and medetomidine in the drug supply. With that, we have a deck. I'm not quite sure. Sarah, are you able to pull up the deck by chance? Let me see. Okay. Do we have the deck by chance? If not, I can try and share screen. Give me 1 second. I'm sorry about this technical glitch. Oh, thank you, Sarah, for coming to the rescue. All right. So if we could move to the second slide, please. And I'm joined today by Dr. Kalyana Raman, Deputy Secretary for Public Health. We also have Dr. Rachel Talley on the line, who is our Chief Medical Officer for the Behavioral Health Administration. So during our conversation today, what we'd like to walk through is start with a review of current overdose data and adulterant trends that would include xylazine and medetomidine. We'll then review recommendations from the Xylazine and Maryland Work Group report from 2022 and share updates on recommendations and implementation. Lastly, we'll take a look at emerging trends related to medetomidine and the response efforts. And then we'll hope to leave some time at the end for questions and answers. And with that, I will turn the floor over to Dr. Caliana-Rahman.
Thank you, members of the committee. Good to see you again. Thank you for having us here. Next slide, please. So I'm going to talk a little bit about the data that we have, the total overdose deaths. We have this data is available on our website. It's publicly available data. It's one of the things that we've worked on in the past couple of years to make sure that we have data that's out there and available for the public to use. And we continue to monitor both fatal and non-fatal overdoses and share this information. So this first slide, I think, is the baseline of how we think about overdoses. Right? We have talked a lot about this over the past decade plus, but we really did see a slowing and then a reversal of the overdose trend to the point now where we saw a significant decrease just in the past year in terms of overdose deaths. That number of 1,648 is still preliminary, but it's not going to move too much further. We're still just finalizing some of the data from 2024. But as you can see, in 2020, 2021, we saw a flattening of this overdose deaths per year, and then slow decreases in 22 and 23, and then a sharper decrease now in 24. Next slide, please. And when we look at that data, we're looking at what are the substances that are involved. You'll note that the numbers here don't add up to the deaths that are recorded because multiple substances may be present. But the top two, as we know and as we've talked about, are opioid-related and fentanyl. And opioid-related contains a wide variety of opioids that are in that category. Delegate Pippy.
Yeah, and Madam Chair Bagnall, I apologize in advance. I have committee at 12:30, and I just wanted to highlight a point, if I could, if you were okay with that, before I have to go.
Go ahead, Delegate.
Okay. So to the Department of Health, I was somewhat surprised to see this chart because there is a nearly identical chart that I provided to the chair of the committee and the subcommittee chair, Bagnall, that includes xylazine on it, which shows the deaths going up. And it's a nearly identical chart to this, except it lists xylazine on there, and it's from the Maryland Department of Health. And so I'm just not quite sure why we would maybe inadvertently omit that chart, because this is a xylazine briefing. You're showing that overdoses are going down, but yet xylazine-related overdoses are going up. And so, maybe if you could chime in on that so that everyone has, most up-to-date and accurate information.
So why don't I, Delegate, to your point, we have more data coming that's going to talk specifically about xylazine. So with respect to the fact that you're going to have to leave in 10 minutes, I will get to that in a moment. So,
and thank you for Delegate for making us aware of your time constraints, because obviously we want to make sure that we are getting to the data. And so thank you, Dr. Caliana-Rahman, for being accommodating.
Sure. So this is 2023 data. I'm going to the delegate's point, I'm going to skip the next slide and then go to the following one, which talks about xylazine specifically, to your point. This is we broke it down year by year, and we were looking at the proportion of folks who were decedents, who had died, who were xylazine positive, right? And to your point, Delegate Pippy, this is that data we're looking at. We pulled it out, and we see an increasing level of xylazine present in those overdose deaths that were growing, with the highest in 2021 of 20.5, we saw a decrease over the next couple of years to 10.7% in 2023, and then a rise last year to 18.4% in 2024. Most of the decedents who test positive for xylazine had illicitly manufactured fentanyl, and we make that distinction from pharmaceutical grade fentanyl as their cause of death. And that, you know, as you can see here, that over 99% of those xylazine positive overdoses has had the fentanyl as a cause of death in 2021 and 100% of them in 2023, right? And so I think we know this, right? That xylazine is admixed in with the illicit fentanyl, and that in large part that is where we're seeing it, right? We don't see xylazine on its own, but it's because it is part of what is available in street drugs, in that fentanyl or other opioids that we're seeing this issue. Next slide, please. And this data is just to make this a little bit more visual, right? Sometimes those words are, I prefer a good graph. This helps demonstrate what we were talking about in the last slide. It's a little bit wonky. That's why we wrote it out, so that it's a little bit clearer to understand, but it shows that increase, that decrease over 22, 23, and that increase back up again in 24, broken down a little bit more by months, so it's a little bit smoother over time. Next slide, please. And so that data was for people who had died. But then we also have data, and I'm going to pass it back to Deputy Secretary Lord to talk about the data that we're seeing in people who are actively using, but are still alive.
Thank you, Dr. Kalyana-Raman. And so, as you see here, the Rapid Analysis of Drug Program has been in existence since 2021. And through RAD, we look to address three major goals. So we want to improve the understanding of the Maryland drug market landscape. So as Dr. Kalyana-Raman said, for those that are actively using, what are we seeing in the supply? Empower people who use drugs with knowledge about the drug supply to inform their decisions and reduce risk. So this is really the harm reduction and prevention approaches. And provide critical information about the trends that we are seeing in our data, and then support this through various different programmatic initiatives. And that includes, for example, our syringe services programs. I do want to caveat that just like with any data, there are some data limitations. So RAD is comprised of convenience sampling. And so what that means is it's completely voluntary amongst our syringe services programs participants, and they can choose to engage in it or not. There's no personally identifiable data that is collected. Therefore, we don't know how many participants are accounted for in the sample size. And it gives us an indication of real near-time drug market supply in Maryland, but it should not be considered fully representative for the other two caveats that we've called out. But nonetheless, this is an important source of information for informing what is happening in the state of Maryland and for those that are utilizing substances. Next slide. So what you can see here, hopefully, and I think we're happy to share the deck after the call, is that the RAD data is displayed by quarter. In 2024, xylazine is brown, second from the top. And what we will notice is that there is a decrease in Q3 and a slight increase in Q4, but it is still lower than Q1. And some of this could be comprised of who the participants were that participated in the sample. Again, they're the data caveats, but at least we wanted to be able to demonstrate that based upon the samples that we're seeing in the supply, we are seeing a decrease. I will also say in a couple of slides, we're going to talk about metadamidine, but you can see that represented here in the light brown line, the third from the bottom, showing a slight increase in Q4. Next slide. And these are some additional RAD data that we wanted to share. So this is for Q1 of 2025. So this is the most recent set of data that we have. So for about 15.5% of samples tested in calendar year 25 that's January through March, contained xylazine. That is a 48% decrease from the previous quarter and a 59% decrease in samples containing xylazine from the same time last year. And again, this data is preliminary and subject to change, but we wanted to share with you what we had most immediate. Next slide. And with that, I'm going to turn it back over to Dr. Kalyan Raman to talk about the xylazine in Maryland work group and the report.
Happy to, but I just wanted to note, Delegate Pippi, if you have any questions, because I think your time is running short with us.
Yeah, and I appreciate that. So, look, I'll just summarize. Obviously, the committee probably remembers the bill presentation. What's been shocking is that although opioid deaths in general have been going down, or at least going in the right direction, it appears that there is a resurgence of xylazine and medetomidine, which are animal tranquilizers that folks are starting to mix in with other things. And so, just we're doing our due diligence to keep combating the opioid crisis. And I want to make sure that we do something about these two substances, because it appears that there's nothing that would prohibit the use of these, even though every state around us has scheduled it. Maryland has not. So, we have to ask ourselves, why is Maryland the only state out of every state that surrounds us that has not scheduled these drugs? And the fact that there is zero human use for these drugs, and my bill still said you could use it for veterinary purposes, you just couldn't use it for human purposes. But anyways, that's really the gist of it. And I appreciate the health department presenting this information. I'll let you guys continue. My staff will be here. And then hopefully we can follow up with further conversations on how to address the issue.
And thank you. And we're going to talk more about the scheduling piece as well. So I'm sorry you won't be here, but we will address that. But I think the core issue is we're looking at all of the impacts. But I think that warrants a little bit longer conversation than me trying to cram it in 10 seconds. So
yes, sir.
And Dr. Kalyanaram, I'll just intervene to say that this briefing is also being live streamed. So Delegate Pippi, you will have the opportunity to hear everything that is said, even if you're not available to remain in the briefing to ask questions.
So we had we commissioned work to look at xylazine in Maryland, and this report gave its recommendations in 2022 because we have recognized the impact of xylazine for a number of years now, right? Going back to 2019, we shared some data, so we're 6 years in, and probably I think have done some of the best work in the country on this issue. And so when we looked at xylazine in Maryland in 2022, there were a number of recommendations that came out of that work. One is to build and maintain an infrastructure to respond to that problem. And Deputy Secretary Lord is going to talk about the steps that we've taken to address xylazine. Its use and what we're doing to mitigate that. Key is also, everything we do in public health is to continue to monitor the issue and the data. That's why the rapid analysis of drugs was such an important pilot program and now is beyond a pilot, because it gives us information not just after somebody has died, but to try to get some sense of what's actually happening in near real time with people who are actively using right now. And so understanding those issues, both related to morbidity, so death, or just mortality, harms, and diseases, particularly the skin infections that come from that, is really critical. And then looking also at the demographics and the geography of those overdoses involving xylazine. Making sure the third recommendation was making sure that we're disseminating information about this problem. And we've been working with stakeholders on this issue throughout Maryland and with our partners in other states as well, including assessments of people who are selling and using this to understand what's happening. And we partnered with other institutions to do some of this work. And then investigating the factors underlying the emergence of xylazine in the drug supply. And I think there's an unfortunate but long history of various substances being used to cut or potentiate the effects of first heroin, now fentanyl, in our drug supply. And you see this with other drugs as well, but focusing on opioids, those are the two major ones. Next slide. And so I'll start here. Our building and maintaining this infrastructure to respond to the problem. As I mentioned, we looked at this. We looked at this problem, formed this work group in 2021, came with our recs in 2022, and had an addendum in 2023 that we're continuing to follow. Part of this is our OD2A, or Overdose to Action grant that we get from the CDC that really invests in this emerging drug surveillance infrastructure. So part of this is implementing testing protocols at our Office of the Chief Medical Examiner in terms of funding for staffing, equipment, supplies to be able to do this testing. That's why we're able to pick up the xylazine in those decedents. Having our emerging drug trends work group established, expanding that. They're the ones who are really looking at what are the emerging drug trends and what are these adulterants that we're seeing. And then also staffing epidemiologists to be able to look at this data, analyze it, provide support and information for not just for us, but for the public as well. And I'll turn it over to Deputy Secretary Lord now to talk about our prevention and response efforts.
Thank you. So in terms of what the department has been doing, it's really trying to figure out how do we get upstream in partnership with our locals and our communities. And the other thing that we've tried to do is really tick and tie this to other work that's been done so that we're not operating in silos. So what you'll see here is somewhat reflective of the overall alignment with the Racial Disparities and Overdose Task Force report recommendations that were issued in 2022 and operationalized many of those recommendations. So a couple key things to highlight. So we've modified education for our nearly 300 overdose response programs across the state. We have to make sure that CPR training is conducted alongside naloxone distribution. We have distributed more than 140,000 xylazine test strips to local overdose response programs through our centralized distribution model. You heard us talk about the development of the rapid analysis of drugs, and we have looked to expand wound care capacity across the state, both through trainings for clinical and non-clinical staff, but also supporting at the local level wound care initiatives. And then we have an investment in the JHU Check It, which is a mobile unit in Baltimore and Cecil County that is utilizing machines for on-demand results for supporting some of these efforts. And so I think the other piece that we've really tried to take a look at is, how do we increase implementation of telehealth and low barrier access to care? We have certainly utilized the state opioid response monies that we've received to make sure that we are building further capacity across the state. And really with those grants, they are identified by the community as to what is needed to help better shore up the infrastructure for supporting those that are actively in use or in response to where we're seeing increases in overdose. The other pieces that we have is we've continued to fund the Maryland Addiction Consultation Service, which we've been supporting for years, and they provide technical assistance across the state for clinicians who are working on complex cases. And this has been a real added benefit so that we come together and also allows us to discern themes and trends and then work with MACs to make sure that we're providing additional education and training. Next slide. And then I think I'm sorry, was there a question?
Go ahead.
Oh, go ahead, Nilesh.
Yeah, no, I was going to say that we're continuing to monitor the issue. This is where Deputy Secretary Lord, the reason we're going back and forth is this occupies both of our departments, both public health and BHA, right? This is a core function of our continuum, and so we're continuing to monitor this issue. I mentioned our emerging drug trends work group. We continue to do qualitative evaluation, not just the data, but also qualitative interviews with residents around key problems, recommendations, particularly wound care. That's been a big focus of the work that we're doing to make sure that we're incorporating that. Wound care complicates treatment for substance use disorder significantly. It's a challenge that we and others face as well. I think Deputy Secretary Lord mentioned our award to Hopkins, and some of the findings that we're just getting just last month are that xylazine-related withdrawals are more severe, which makes it harder to treat and makes detoxification harder if people are going to go into detox and withdrawal management, and makes treatment of the wounds as well much more difficult, right? And at the same time, while test strips and drug checking are helpful, there isn't a lot of choice that people have in the drug market. And so it's important to know, but there isn't always a way to pick something that doesn't have xylazine. It may lead to greater awareness, greater utilization of opiate reversal, but also awareness of others that an overdose may be more likely with that. And then I'll pass it back to Deputy Secretary Lord.
Thank you. So besides what you've heard in terms of these other interventions and strategies, there is another area that we're working on, which is how do we continue to make sure that we are sharing information in close to real time and deploying any and all strategies that are at our disposal, both for individuals in the communities, our community-based providers that are supporting these efforts, our provider network as a whole. And so what we have done is we've invested in public awareness campaigns, made sure that we are thinking this through and that individuals who speak different languages are understanding what we're seeking to communicate, and that we have developed an extensive toolkit that allows for both digital and print ads. We have disseminated a large volume of xylazine fact sheets to the general public, to those that are using substances, and to providers. There's social media content. I mean, the bottom line is we are looking to address this in any which way that we can, because we know that people receive and access information and services in many different ways. The other thing, as Deputy Secretary Kellyanne Rahman has stated, is that this is a shared effort across our department. So there is core investments being made between our two respective teams. And as such, we're making sure that we're bringing together our stakeholders on a regular basis to talk about what we're seeing. So there are standing meetings with our providers, with our grantees, to learn what is happening and what we're seeing from the data and how that translates into real practice. Deputy Secretary Kellyanne Rahman, back to you.
All right. And so next slide, please. And so one of the big things that I think we're here to talk about is investigating the factors underlying how xylazine has emerged into the drug supply, right? And this is something that we've looked into. So in 2023, we explored the impact of xylazine scheduling. It was one of the first things that I recall doing with my team when I started, was to look into this issue. We got advice by our legal counsel to understand the complete scheduling process, and there is a scheduling process that we can use through the department, and then of course it can also be done legislatively. We engaged the Maryland Department of Agriculture and the Veterinary Association to understand the impact, because as Delegate Pippi noted, this is a medication, but it is medication only for animals. It is not authorized for use in humans. We did get a guidance and advice from the Office of the National Drug Control Policy, the ONDCP, and actually in 2023 they also put out their roadmap for xylazine as well, and I'll talk about that in a second. And lastly, getting technical assistance from the National Governors Association, where this was being discussed quite seriously at that time. It still is, but there was a lot of movement at that point. And I think the thing that I learned from that time that I think is really important to understand here is that, we partner with the National Institutes of Standards and Technologies, NIST, who's at Frederick, as part of this RAD program. And what they've determined is that the xylazine that's being discovered in the street drugs is illicitly manufactured, right? And that would minimize the impact of scheduling on the drug supply characteristics. Scheduling is going to affect any legally produced and distributed xylazine. Illicitly manufactured xylazine isn't going to be impacted by this, and in fact, the ONDCP, as part of their roadmap, said that on the issue of scheduling, that the issue is being actively looked at, but it's part of a larger look at understanding what is the scope of scheduling, how would that interact with interdiction efforts, which is, I think interdiction efforts are probably going to be more effective in terms of what we're seeing here. And so the FDA has taken actions to restrict unlawful import of xylazine, right, to address those interdiction efforts. And I think the corollary to this is that one of the things that we see with scheduling of these illicit substances is that in some of our neighboring counties neighboring states who have done this, we've seen a much larger increase in medetomidine substitution. We're going to talk about medetomidine in a moment, but medetomidine substitution for xylazine. Now that muddies the waters a little bit, right? If we're seeing that substitution effort, maybe it does have an effect, but maybe not the effect that we wanted, which is we're seeing one drug replaced with another. It's not to suggest that we should or shouldn't schedule, but it's just that the data is really not very clear that there's a meaningful benefit here. And I think that's the issue, and that's what we should be discussing, is what are the avenues that are going to help with this, and what are the avenues that are maybe not as productive or maybe even potentially counterproductive. And I think that's the core of the scheduling question, but it's also just one piece of the larger texture of how we are trying to address xylazine, medetomidine, in the illicitly manufactured fentanyl supply, which is predominantly where it's showing up. We're gonna talk about medetomidine now, so I'm gonna turn it. Gonna get I think 2 more slides. We have 2 more slides to talk about medetomidine because that's just a newer drug in the supply, and then we can open it up for any questions and thoughts.
So medetomidine, similar to xylazine, is a veterinary anesthetic and sedative. And so over the next 2 slides, we'll talk through the data that we've been able to capture. And so what you see here are the medetomidine positive RAD samples. This shows the data trend over the past 4 or so years. And so there's a total of about 3,500 samples total that have been tested via NIST since October 2021. And what we are seeing is that in Q4 2024, within the RAD samples, about 8.5% included medetomidine, and this was across 69 samples in 10 jurisdictions since October 2022. And what we've seen to date is that the peak of 46 medetomidine positive samples in 2025 of Q1 was out of 270 samples. What I can share with you is a bit of the breakdown by county. And so where we are seeing positive samples are in Allegheny County, Baltimore City, Baltimore County, Calvert, Cecil, Frederick, and Howard. I will say in terms of the preponderance or the larger incidence, Cecil and Frederick is where we're seeing the larger numbers. And that was in state fiscal year 24. For state fiscal year 25, we have seen Allegheny, Calvert, Cecil, and St. Mary's submitting RAD samples with positive medetomidine. So again, that is a small snippet of just Q1 2025. We've not received positive samples from any of the other jurisdictions, but that's a comparison between 2024 and 2025. Next slide. So what are we doing, right? So with that, I will turn it back over to Dr. Caliano.
So the concern with the medetomidine is that it's about 200 to 300 times more potent than xylazine. This is kind of mirrors the same problem we saw with fentanyl and heroin, right? Fentanyl substitution, it was much more potent. We saw that briefly with carfentanil and fentanyl. Mercifully, we don't see carfentanil in the supply right now. That was anyway. So as I said, that's mirroring this problem of medetomidine showing up to substitute for xylazine. We haven't seen any fatal overdoses with cause of death being medetomidine, but we are seeing increased prevalence across the East Coast in 2024. as I mentioned, we're seeing some severe worsening withdrawal amongst folks in Pennsylvania. And here's where that data is mixed, right? On scheduling, how much impact does it have? And when it does have that impact, is that impact beneficial or harmful? And I think that's the hard part that we're still trying to work through, right? Is we want this impact to be positive. We want this impact to decrease, scheduling of xylazine to decrease the health impacts, not to lead to substitution of something more dangerous. And that puts us, that's a tough place to be. And I think that warrants more conversation. But similarly to the xylazine, the source of medetomidine is being identified as illicit manufacture, right? And that once again gets to the question of, if it's illicitly manufactured, what is the effect of scheduling? Still puts that into that tough to answer category, right? And so we're going to continue collecting this data, collecting the RAD data, looking at our mortality data from our decedents, and continuing to try to understand what's actually happening here and what that trend looks like in concert with our states that surround us. And so with that, I think we'll end here, and we're happy to answer any questions that you have.
Thank you very much. Thank you for the presentation. And I'm going to open it up to the members. I see a hand from Delegate Chisholm.
Thank you, Madam Chair, and thank you for the presentation. So if it's illicitly being manufactured, is it a pretty simple drug compounding wise for them? My initial thought was, were veterinarians ordering it, some nefarious, and then putting it out on the street, or is it somewhat easy to, I guess, manufacture through compounding agents or whatever? And my big question is, do we have a way of finding out, obviously the source of it and cutting off the source? So it sounds like more and more of it's getting out there. And is there a demographic that's using it mostly? Is it, high school kids, college kids, or is it a broad range as far as we know?
So I'll take the first part of that in terms of where is it coming from? That's where we rely a lot on our federal partners, DEA and FBI particularly, are looking at this, and we have meetings with them around this. So the two at least for xylazine, the two main sources are the illicit manufacture. It requires some chemistry knowledge, but there are chemistry labs we know, right, that are manufacturing illicit drugs. So it's not simple to make. It's not like the stuff with Sudafed that we're talking about, like meth. This is different. It requires more expertise, but it is happening. And the other thing that we're seeing, and I don't have numbers on this, but is that I think it's the medetomidine that's being diverted is from distributors, not from prescribers or pharmacies, but from distributors, right? And so before it reaches the clinical side of things, it gets diverted. And that's why I say interdiction is actually, I think, really important in these spaces, right? That goes beyond the health sphere into our law enforcement sphere. And on the second piece, right, who's using it? I'll defer to Deputy Secretary Lord on this. I don't remember the demographics from age off the top of my head.
Well, I think if we just take a look at where we're seeing it across the state, it's impacting a majority of counties, right? So we've gone from eastern to central to a little bit of, western to central to a little bit of eastern Maryland. So we can certainly follow up on the specific demographics, but for 24, we saw some variability across the state. So it's entering the supply regardless of the age or where people are accessing substances.
Okay. Thank you both. I appreciate it. Appreciate the briefing.
Thank you, Delegate Chisholm. Delegate Hill.
Yeah, thank you. Thank you for the briefing. I guess it's nice to see the trends, but I just need some clarity. Is the issue about whether we should explicitly make this legal or schedule it, illegal or schedule it or whatever, that you're seeing it as an adulterant, and we're not seeing it as, being used, either of these being used independently. It's not clear from your data how its use as an adulterant increases or changes the impact of the other drugs that it's mixed with. So I'm not really clear, other than, I've read some of the DEA stuff about the side effects and lowering blood pressure and other things to do, but you haven't really helped me understand why as individual agents, there is so much focus on that. There are lots of adulterants that are around. So maybe, I'm not sure if I'm being clear.
Yeah, I'll start. I'll start with this, right? So these adulterants tend to potentiate or provide a stronger effect of the opioid, typically fentanyl, right? And so xylazine in particular potentiates that effect, creates that sense of falling down a hole, getting being disconnected, right? And as with any of these adulterants, they're trying to find a way to cheaply get into to make the effect better at a cheaper cost. So I'm not aware of any solo use or solo sales of xylazine. Medetomidine, I don't think so. That's new, and everything we've heard is that nobody is seeking xylazine, right? People would try to avoid it if they could, but don't have that choice to always do so.
Right. So test strips so people know that it's adulterated, that it's contaminated, that the effect, if they're using illicit drugs, may be worse, are important. But if you're already illegally selling fentanyl or opioids of any type or any other medication, and you're adding xylazine, adding a different level of criminality to the xylazine, if I'm hearing you, doesn't really change the impact on illicit drug users in terms of it's not going to have a dealer go, oh, you know what? There's a fine for the xylazine. So I'm not going to sell the xylazine. I'm just going to sell the fentanyl. Is that the idea here? I'm not.
Yeah, I don't think we've ever seen evidence that, right, that and in this instance, we're talking about scheduling, right? That because of the way that it's being introduced into the drug supply, either illicitly manufactured or diverted from distributors, it's not really the scheduling is not really going to change it. It might shift some of the distributors and what they're doing and tighten up their practices, but all of the illicitly manufactured xylazine and medetomidine, they're illicitly manufacturing it, right? Scheduling it isn't going to shift their illegal behaviors.
Okay, thank you. Thank you, Madam Chair.
Thank you very much, Delegate Hill. Do I have other questions from the members? Delegate Hill.
I'm sorry. How is this different from kratom? And what was the other drug that we made illicit? How are these two different?
INFP was the other
Right.
one.
Right.
No.
So why are
And
they
Phenibut this session,
Right.
because we modeled the Phenibut
Right.
legislation
why
on
was that? Or
kratom.
do you consider that was appropriate past legislation that we passed? Why is this different?
So these substances, are kratom and tianeptine and now phenibut, they're not regulated by the FDA, whereas xylazine and medetomidine are regulated by the FDA, right? Those are legally available medications, xylazine and medetomidine, but not for humans, only for animals. The other three, phenibut, tianeptine, and kratom, don't have any standing. So that's why they can be sold, right? They're legal to be sold, but we as a state decided to put restrictions on them because they do have health effects. And I think you remember, Delegate Hill, there was a difference in even how kratom and tianeptine were handled during the legislative session last year because of that. And so while there are harms with those substances, the harms are different and the harms are generally lower, right? But still there by all means. And so I think that that's the nuance in this, is trying to negotiate what are the harms, what are the potential benefits. We don't really see any in the xylazine and medetomidine space, but we always have to ask that question.
And Dr.
Thank you.
Kalyana Raman, correct me if I'm wrong, but to further clarify too, kratom, tianeptine, phenibut, they were available in stores. Like you could actually
Correct.
go to a retailer. Xylazine and medetomidine, they're not in retail establishments. Is that correct?
Correct. It is not legal to purchase it that way.
Are there further questions from the members? All right, I've got a couple questions, but I wanted to give our members the opportunities to ask first. Obviously this is a concern, and we know that the delegate brought something forward because we want to do something, and it sounds like we are doing a lot. And I think the question we're asking is what more can we do? Are there legislative efforts which would aid the department in your efforts to rein in this adulterated substance into our illicit drug market? And or is that a conversation we can continue to have? And is this the space in which our our overdose prevention sites are sort of acting as the bridge, that we don't have overdose prevention sites, but we do know that we have mobile interventions currently that are providing wound care, that are providing the testing strips, that are providing those services that we're seeing a greater need for as we have these adulterated substances that are creating these greater withdrawals and increased overdoses. And my final question is, are we seeing a trend of non-fatal overdoses, medetomidine and xylazine? Because I know that we've done a lot to try and prevent fatal overdoses, but what can we do to address this? And is there something legislature can do to aid the efforts of the department?
I'll start and then I'm gonna pass it to
A question in 7 parts.
yeah, I'll start here and then I'm going to pass it on to Secretary Lord. I think in terms of like legislative efforts, I think we need to follow up on that, right? To think through what it is that is needed to push forward on this issue. You know, some of the hardest things to deal with are these emerging drug trends, because it's challenging to even categorize it properly and what is the right set of interventions. That doesn't mean we're not going to intervene. It's just figuring out what the right ones are. But that's kind of my initial impression.
Yeah, I think I agree with Dr. Kalyana Raman in that I think we just appreciate and value the ongoing dialogue and support. And that one of the things between our respective teams that we're doing is really taking a look at the data that is coming in around these emerging themes and trends, and making sure that we are pivoting and adjusting within the confines that we have, right? You know, so, and I know at the state and at the federal level, it is a difficult funding time. So trying to make sure that we are utilizing the existing resources and assets that we have. And so I think, you know, over the next 6 to 12 months, as we build up this further database of information and how we're thinking about evaluating the outcomes of our programs, it will help to give some further insight as to potential future legislative actions. And then regarding your question about non-fatal, I think, Nilesh, I don't have that data at my fingertips. So I think we're going to need to come back to you, Delegate Bagnall, if that's okay, with additional information about whether or not we're capturing the non-fatal overdoses for medetomidine.
Yeah, and that's, you know, I'll just talk briefly about one effort we had, which was to provide funding to the University of Maryland to test urine samples of folks who came in with an overdose for illicit substances, kind of an expansion of the RAD program, right? The RAD program is for people who are using and voluntarily submitting materials. And that was a small program. Funding, I think, is one of the issues that we have, but also how useful is it? And we can follow up with, you know, information from that and what we saw. But, you know, for a program like that to work, it has to be continuous, and that's a challenge in this universe, right? Where do we put our limited resources?
Well, thank you very much. I think it's clear from this committee and the subcommittee that we are very dedicated to making sure that we are furthering this effort, because we know that this is a huge challenge. I did have one final question. Just you had spoken to the concerns and the rise of medetomidine in states that had scheduled xylazine. Are you seeing any efforts to then schedule medetomidine, or are we? I think Dr. Kalyana Raman, you and I had talked about the other space, the unregulated space, and maybe looking during the interim at what we could do so we don't have these substances such as phenibut and kratom, you know, constantly entering the market. Are you seeing from other states an effort to look at these other substances, or are they sort of in a holding pattern saying, well, we've scheduled xylazine, so now we're waiting to see what happens?
I'm not aware of medetomidine being scheduled in any state at this point. That doesn't mean it hasn't been. I'm just not aware of it. I haven't heard of it. I think part of it is that it's just so new, that it takes a little time for folks to figure out, is it gonna remain or not. I think carfentanil is a good example of something that was new, dangerous, but also receded.
Thank you very much. I see no other questions from the members. I really appreciate you all being flexible. I really appreciate the department making sure that we had that we were able to conduct this briefing with our sine die schedule looming. So with that, I'm going to go ahead and conclude this meeting. I just ask the members, stay tuned to your email because we still, as you know, we still have some outstanding questions to answer. And I really appreciate you all being Gumby, as our chair says. So thank you very much, and I will see you all at 2 o'clock for committee.
Thank you.